Hello, everyone. I'd like to welcome you to this month's Lunch and Learn. We're in for an amazing program today. I'm going to turn things over to our moderator in just a moment, but I do want to start by acknowledging and thanking our sponsor for our entire series this year, and that's Crown Automotive Charities and the Hawkins Family Foundation. They are sponsoring all of the Lunch and Learns for 2023, and also our small group gatherings, our salons that we are holding throughout the year. If you would be interested in holding a private small group talk with a mental health professional and someone with lived experience to increase the conversation around mental health and suicide in your own home, please contact me at contact@loveforlawrence.com and we can have a discussion about that. Now I'd like to introduce you to Dr. Jeffrey Bornstein, MD. Dr. Bornstein serves as President and CEO of the Brain and Behavior Research Foundation, the largest private funder of mental health research grants. The Brain and Behavior Research Foundation is the organization facilitating our talk today. Dr. Bornstein developed the Emmy-nominated public television program Healthy Minds and serves as host and executive producer of that series. The program, broadcast nationwide, is available online, and it focuses on topics in psychiatry in order to educate the public, reduce stigma, and offer a message of hope. Sounds familiar. That's the mission of Love for Lawrence as well, so we certainly love that. Dr. Bornstein also serves as editor-in-chief of Psychiatric News, the newspaper of the American Psychiatric Association. He's a fellow of the New York Academy of Medicine and serves as the chair of the section of psychiatry at the Academy, and is the immediate past president of the New York State Psychiatric Association. Dr. Bornstein earned his undergraduate degree at Harvard and his medical degree at New York University. And I thank you for being our moderator for the program today.
Thank you, Stony, very much for such a nice introduction. Thrilled to be a part of this, and I want to thank the Dimmitt family for all that they have done, continue to do, and will do for this such an important cause. I also want to thank our chairman of the board, Jeff Simon, who actually introduced Love for Lawrence and BBRF, and just as importantly, thank Marty Burrell, who serves on the board of Love for Lawrence and is recently joined the board of BBRF, furthering the ties between both organizations, which is so very nice. The Brain and Behavior Research Foundation is the world's largest private funder of mental health research grants and is a collaborative between the scientists and our donors. A key focus is on supporting young investigators who have new ideas that can really make an impact on psychiatric care. So with that, I'm going to introduce Dr. Durga Roy, who in 2018 received the BBRF Young Investigator Grant. Dr. Roy is the medical director of the Johns Hopkins Bayview Neuropsychiatry Clinic and associate professor of psychiatry and behavioral sciences. If anybody has any questions, please type them into the question thing. We'll get to as many of them as we can after the presentation. And with that, I'm passing the baton to Dr. Roy. The Zoom is yours. Please take over.
Thank you, Dr. Bornstein, for such a wonderful introduction. I will go ahead and share my slides. Are you able to see them? Yes. Okay, great. I have two disclosures. One is that I was the co-investigator of a very large study done at Hopkins in traumatic brain injury called the Head Smart Study. And as Dr. Bornstein mentioned, I'm also the recipient of the 2018 NARSAD Young Investigator Award. The psychotropic drugs that I'll be talking about briefly today are also not FDA approved for use in traumatic brain injury, and many are used off-label. Over 10 years ago, after finishing fellowship, I was tasked with the role of taking over the Johns Hopkins Brain Injury Clinic. And at the time, there was a common belief amongst doctors that when someone had a head injury, we really should be worried about their physical symptoms, their neurologic problems, and that their psychiatric illness or the emotional symptoms that came about really weren't much of a priority. Over time, I started meeting several patients, which really changed that thinking and that mentality. Let's start with my first patient. We'll call him Ron. Ron was a middle-aged, very successful business owner, had a massive entrepreneurship. And one day during lunch, he was driving and he was T-boned. He lost consciousness for a mere 30 seconds. He went to the ER, he was discharged with a diagnosis of a mild concussion, and he went about his way. But the aftermath that ensued was very real. He started forgetting things. His wife would send him to the supermarket and he'd forget the list that she gave him. He would start blurting things out when he was at dinner table, things that were very embarrassing and problematic. He would go to the bank and start yelling at the bank teller unprovoked. He would start getting into fights with drivers in the parking lot of a mall. Over time, he started to deteriorate in terms of his memory. His family members would say, well, you don't look like you had a head injury. You're talking normal. Get over it. Workman's comp would not pay him a dime because his brain imaging findings were quote unquote normal. And yet a bright, enthusiastic, successful business owner stopped being able to balance a checkbook, stopped being able to get along with his family members. And over time, he went bankrupt, his house foreclosed, and he continued to struggle. This was all because of a traumatic brain injury. Let's take my next patient, Joni, we'll call her. Successful physician, top of her field, very well recognized, crossing the street one day and was broadsided, hit by a car as a passenger, was struck as a pedestrian, fell down and suffered many orthopedic injuries. Over time, her pain became very severe. She struggled with something called the complex regional pain syndrome, CPRS. She became extremely depressed, requiring multiple psychiatric admissions. Over time, she had to stop practicing medicine and now struggles to hold on to information that she reads when she's reading medical texts. And this was all because of a traumatic brain injury. So what are we going to talk about today? Today, we're going to talk about what are the common neuropsychiatric symptoms that people encounter after a traumatic brain injury? And what are some of the common treatment interventions that we're doing to treat these symptoms? And then finally, as a community, as a group of people, how can we list and ways that family members, that patients, and that we as providers can engage in recovery for their loved ones? Because we really want to think about not just getting better, but staying better and giving hope as people go on their path of recovery. We first want to start to talk about what a TBI is. So TBI is the acronym for traumatic brain injury. I'll tell you what it is, and I'll tell you what it's not. It is a sequence of events. So it's not a one and done, got hit to the head one time, and that's it, we move on. There are several consequences that come after it, and it's really an outcome that's often related to a cause. It is a chronic condition. What it is not is it's not a disease. It's not something one is innately born with, that they inherit, that's genetic. So that's a big point to think about as we look at the trajectory of someone's life after a TBI, because it is generally a sequence of events. TBI is a big public health problem. About 3.6 million TBIs occur in the US annually, and about 3.2 to 5.3 million people live with some level of a TBI-related disability. It's a very expensive disease. When we talk about how many people come into the ER or the ICUs, over $60 to $221 billion, both in annual direct and indirect medical costs, are spent yearly just on this problem alone. As we'll talk about later, about 43% of those who are hospitalized for TBI subsequently develop some kind of functional or psychological sequelae that render them disabled. And it is the leading cause of death and disability in people younger than age 45. So if you're an ER doctor in the trauma bay, you're seeing somebody come in with some level of a death or comorbid problem, TBI-related deaths is very, very common. we talk about what a TBI is, in order to be defined as a TBI, we have to look at two components. The first is that there's an alteration in brain function or brain pathology that's caused by some kind of an external force. What does it mean to be external? It's something coming from the outside of the head and the head getting struck or being struck. So you see that it doesn't matter where the impact is, there's an external force to the head. Alteration in brain function really is characterized by four main things. Altered mental status, which is sort of, we ask patients, were you dazed, disoriented, confused? Loss of consciousness, did you black out? And if so, for how long? Amnesia, did you forget things before the injury or potentially after the injury? And neurological deficits, are you having any weakness in your muscles, or are you having blurry vision, any other kinds of hearing loss, etc. Oftentimes, there can be evidence of brain pathology, but not always, like my patient Ron. His MRI findings were normal, and we'll talk about how some nuanced aspects of mild TBI or concussion can often go undiagnosed. But there oftentimes can be evidence of pathology, like we see on CT scans with brain bleeds in brain imaging. Sometimes post-mortem, we see things on autopsy findings. So this is a picture of the brain of a retired NFL player who had repeat concussions to the head, and there was shrinkage of various aspects of his temporal and frontal cortex. One thing that always gets confused, is it a brain injury or is it a traumatic brain injury? Well, firstly, all TBIs are definitely a brain injury, but not all brain injuries are TBIs. What does that mean? Well, there are other types of brain injuries one can have that are acquired that are internal and not due to an external force. For example, things like strokes, tumors, brain surgeries, infections. And a TBI, as I mentioned, is definitely something that happens from a trauma secondary to an external force, from a car accident, fall, blast injuries, people who are in combat, they're exposed to IED explosions, sports injuries associated with the blow. Oftentimes, when you look at the epidemiology of the most common causes of TBI, particularly in the US, by far the number one are falls. We have a growing geriatric population. In this day and age, a lot of our elderly are having problems with balance, with gait disturbances. So falls are a really common reason we see people coming into the emergency department with TBIs. The next are motor vehicle accidents. So as we mentioned, my patient Ron, for example, getting T-boned. We want to ask specific details about the type of injury, whether they were driving or not, if they were a passenger. Then assaults and being struck by or against something are also the next common thing. Depending on the type of city you live in, if there are high crime rates, you want to be thinking about those. And then finally, this other category of unknown or other, what we're all talking about very commonly these days in the media, sports injuries, sports-related contact, head-to-head concussions that people are experiencing, and this whole concept of return to play. There are different severities of TBI, mild, moderate, and severe. Really, TBI is a clinical diagnosis, so it depends on how long you had what symptom for. So loss of consciousness, altered mental status, post-traumatic amnesia, these are all things that are typically criteria that we use to say that a TBI happened, and how long they happened for is really what tells us whether or not it was mild, moderate, or severe. Now, structural imaging, for example, CT or MRI images, may or might not be normal. And in mild TBI, and this is what makes mild TBI such a challenge, it can often be normal. So people can have a concussion, but their imaging can be completely normal, but yet they still experienced all of these other aspects of losing consciousness for 30 minutes, blacking out, seeing stars, being dazed, disoriented, confused for less than 24 hours, having amnesia. The Glasgow Coma Scale, this is another score that we give to people, and it really looks at three big things: eye movement, motor movement, and verbal movement. And the lower the score, the more severe the head injury. So we use these criteria to identify whether someone had a mild, moderate, or severe TBI. But what's really important to recognize is that it's not related. The symptoms that come after a TBI, the disability that comes after the TBI, the complications that come after a TBI from a psychiatric perspective are not always related to the severity of TBI, even if it's weeks to months after the event. So how is a TBI diagnosed? Well, first is physical examination and history. So the doctor comes, does the physical exam, we look for neurological deficits, we do a brief cognitive exam, And then we do a lot of history taking. So this is where family members really come in handy and really are critical to understanding the story of the patient. Because if we're asking a patient, how long did you black out for? Well, they were out, so they're not going to really remember the details of this. But a family member can say, well, he was a driver, he was belted, he was T-boned. I remember he blacked out for at least an hour, then he came to, he told me he was seeing stars. So family member reports are really, really important. The second thing are other tests that we use, specifically neuroimaging. So really in the ER, mostly what you're going to see are CT scans. And then more specifically, when you want to get more accurate diagnoses and a little bit more detail about brain pathology, we do things like magnetic resonance imaging, MRIs, PET scans, single photon emission computerized tomography, SPECT scans, functional magnetic resonance imaging, and diffuse intensor imaging. A lot of the latter of these, DTI and fMRI, are specifically what my research focuses on, because I'm interested in looking at how functional connectivity changes in patients who have traumatic brain injury, specifically concussions, over time. And finally, neuropsychological tests. Understanding the cognitive function soon after injury. Were there problems with memory? Are there problems with attention, with focus, with executing tasks? These are 3 to 4 hour extensive batteries that patients sit through, which can be somewhat taxing and tiring, but really important to help us figure out what cognitive aspects of their illness is impacting their function. So what happens after a TBI? So you can think of a TBI as a sort of event that happens within a closed encasement. So you think about the brain like this jelly-like substance that's stuck in this hard encasement of a shell called the skull. No matter where the impact of the brain is, wherever the head gets hit, because of these frontal bony prominences in the frontal temporal region, that jelly-like substance gets flung forward into the front part of the brain, and areas get sheared over these bony prominences. What ends up happening is the neurons end up getting sheared too. So you have what we call diffuse axonal injury that results from the brain trauma. This then results in both neuroanatomical changes as well as neurochemical changes. So it's an entire cascade of things that starts to develop just from the shearing of those axons. So because of those two frontal bony spiky prominences in the front of the brain, there are 3 areas of the brain that are the most vulnerable to developing psychiatric problems and neuropsychiatric issues after a TBI. The first is the dorsolateral prefrontal cortex. So this is the part of the brain that's kind of the go, no-go area of the brain. This is the part of the brain that's going to tell you, I'm going to get up in the morning, I'm going to turn off my alarm, and I'm going to go take a shower, go eat breakfast, executing all the tasks. Second part is the orbital frontal cortex. So this is the part of the brain that's responsible for holding back your inhibitions, doing things that are within socially appropriate contexts, not being disinhibited. And finally, the ventromedial prefrontal cortex has lots of different functions, but oftentimes areas of motivation, areas of volition and mood can also be cited here. So what happens when these areas get damaged? Well, in the ventromedial prefrontal cortex, when there are problems, we often see post-TBI apathy. This is the person that doesn't care, but they don't care that they don't care. So they'll say, I don't care if I'm not going to get up and take a shower today. It doesn't really bother me. The key piece about apathy is that this is a person who doesn't have any mood symptoms. They actually have a normal mood. They just don't have any motivation or volition to do things, and that actually doesn't bother them. We have to be careful because oftentimes this can be misdiagnosed as a major depression, which is a very different treatment modality. The orbital frontal cortex, when it's damaged, we see problems with agitation, disinhibition, impulsivity, people blurting things out that are inappropriate. The dorsolateral prefrontal cortex, when this is damaged, as I mentioned, this was the go, no-go system, we see issues with difficulties with planning, having mental flexibility, being able to wait. A lot of times impatience comes about when areas of this brain are damaged, low frustration tolerance, and problems with social performance and different repercussions that might happen. The temporal lobe is a really important part too. And as I mentioned, sitting right over these bony prominences. So the temporal lobe is responsible for memory disturbance and emotional lability, those mood swings that can happen from moment to moment after TBI. And finally, these little tiny baby structures in what we call the subcortex called the basal ganglia. Many of you may be familiar with this area because this is an area that's affected in Parkinson's disease, but it can also be affected in TBI. And oftentimes when there's damage to these areas, we see things like resting tremor, muscle stiffness, and slow body movements. Mood symptoms can develop, and they can oftentimes mimic depression that we see after TBI. As I mentioned earlier, it is a chronic condition, but it's also a big sequence of events. So you think about the initial force, the initial impact is your primary insult. So there's a mechanical force that results in some kind of tissue damage in the brain. But that tissue damage then results in a serious cascade of events that happens hours to days later. So what you end up seeing are things like secondary injury, in which there's a pathophysiologic cascade that leads to further cell damage. Things like inflammation of the brain tissue, neurotransmitter dysregulation, so basically serotonin, dopamine, norepinephrine are all going haywire after this entire cascade has let loose. Oxidative stress, so there's a lot of metabolic changes that are happening to the cells. Mitochondrial dysfunction, mitochondria provide a lot of energy to our cells in the body, and this can also get disrupted. And finally, cytotoxicity, a fancy name for cell toxicity. Basically, cell death happens, and when you have cell death, that means it's the neurons that are dying. It's the astrocytes that are providing blood supply that are dying. It's the oligodendrocytes. All the brain tissue cells start to get affected through these cytotoxic pathways. This then results in what we call post-concussive symptoms. Post-concussive symptoms and syndrome has now been coined as a term that really characterizes a combination of neurologic and psychiatric phenomena. We hear people talking about headaches, dizziness, memory loss, fatigue, poor concentration, double vision. We hear psychiatric symptoms of depressed mood, sleep disturbance, irritability. Oftentimes they're combined, and things like photophobia, which is light sensitivity, or noise sensitivity, can be enhanced, which then in turn worsen mood symptoms. So why is it important to diagnose and treat psychiatric problems after TBI? Of course, neurological problems are going to be at the forefront. That's what's going to take patients to their neurologist or to their primary care doctor. But why is it important that we be very, very cognizant about the psychiatric aspects? Well, you look at TBI as this devastating event that occurs, and whether or not the person had psychiatric illness before TBI, or they develop it for the first time after TBI, combined together, there is a significant amount of disability. We see problems with occupational activities. Patients can't integrate back into the job they used to do. Lots of issues with social integration. They're blurting things out. They're not able to go into social environments and read social cues. And their activities of daily living, like my patient Ron, who could no longer balance his checkbook, no longer really care for himself, really are all consequences when you have a combination of psychiatric problems plus the traumatic brain injury. When we think about common neuropsychiatric disturbances that happen after TBI, we can put them into four big buckets. Emotional, which kind of refers to things like mood, anxiety, emotional regulation. Cognitive, which refers to things like memory, processing speed, attention, focus. Behavioral, which pertains to things that a person does, so being disinhibited, becoming aggressive, becoming agitated. And then the physical aspects, because if you got hit in the head, there are very high chances that you actually got injured in the body as well. And so physical pain is something we don't want to ignore, because they can actually exacerbate psychiatric phenomena as well. But the most important thing to remember is how well a person does after a traumatic brain injury depends on what happened before the injury, at the time of the injury, and after the injury. And that's an important point I want to make here today, because when we look at the prognosis of our patients, it's really important to kind of connect the dots together and see where the patient came from, what happened at the time, and where they are going. You can break down the symptoms into different aspects of discontrol: emotional, behavioral, and cognitive. Affective lability is an example of emotional control. So this is an example of my patient who was basically exploded at the bank teller, my patient Ron that I talked about, exploded at the bank teller unprovoked. Pathological laughter and crying is something that we often also see. This is where you're laughing or crying unprovoked to very trivial stimuli. So for example, when my patient starts crying after watching a gum commercial, which is pretty trivial. Or irritability, being very much on edge, snapping at people very, very readily. Behavioral discontrol, again, talking about what a patient does. So aggressive behaviors, throwing things, banging their head against a wall. Agitation, which really refers to anything that's excessive movement, excessive motor movement, excessive verbal activity, yelling, screaming, and then disinhibition, doing things that are just socially inappropriate. Sometimes people can be sexually disinhibited, say things that are inappropriate to peers, etc. And then finally, the cognitive discontrol, slower processing speed, really taking a while to understand what someone's telling you. Poor verbal learning, not really understanding words that are being told to you, or oftentimes, as my patients say, having a hard time finding words to say. And then impaired executive function, being able to execute the task of getting up, making a grilled cheese sandwich, getting dressed. These are all things that we all take for granted, but really after a brain injury can be severely impacted and significantly affect the quality of life of individuals. So what do family members see? So we hear things like, and this is from a study that was done in 2015, in which particular anecdotes were sort of reported. She loses her temper. She'll get so angry that she's so nasty to the visitors, and very personal, hurtful, terrible things that she says to me. She wishes I wasn't her mom. Or sometimes he feels upset about something, but he can't remember what he was upset about, and he can't remember what triggered it. Or he's very usually used to being very socially outgoing, and now he fears that people will make fun of him. But sometimes he does silly stuff. He might be a little scared that he might blow out, and there's something, and he has to limit how much time he spends outside the house or in the community. We talk about these symptoms, but then when symptoms come together in a cluster and develop over time in a course, that's when we call them syndromes and psychiatric disorders. So across the board, it's well known that people with TBI have a higher prevalence of psychiatric disorders than the general population. So major depression, which I'm going to talk about in a little bit more detail because that is what my research focuses on, is the most common consequence after TBI, and is about 35%, followed by anxiety disorders, substance use disorders, and new behavior problems. And as you can see, compared to the general public, people with TBI have a higher prevalence of psychiatric disorders. Cognitive deficits are high up there from a prevalence of 5 to 60%. And again, as I mentioned, the core features are things like poor memory, poor attention, poor processing speed, and executive function. Depression, we often see times people with very low mood, becoming very irritable, and as I'll get into more depth, having suicidal thoughts. Mania is something that's very rare in TBI, but it does happen. Mania really referring to this state of neuroexcitatory behavior. So for a span of several days, patients remain revved up. They're talking really fast. They have this euphoric mood. They're irritable. They're somewhat impulsive. They're doing things that are dangerous. And the difference between this and that affective lability I was talking about before is that mania goes for a couple of days at a time, whereas that affective lability is mood changes moment to moment every day. So that's not really the same thing as mania. Anxiety. We see this a lot in veterans. So we have a lot of people, a lot of the studies that report a very wide prevalence range from 11 to 70% is because we look at a lot of studies that have people who had pre-morbid or pre-TBI psychiatric illness, but a lot of the times you see people who are veterans and they have a lot of PTSD. So you see a lot of persistent worry, autonomic arousal. They were in some kind of a blast injury or they were in combat. And so they're re-experiencing what they went through. The trauma of the brain injury itself makes a lot of hypervigilance happen. They have a lot of flashbacks, etc. And finally, apathy, as I mentioned before, this is that person that doesn't care, but they don't care that they don't care, comprising about 10% of the patients. There's that lack of motivation. There's no drive. There's no initiative. But remember, there's no problem with mood here. There's a euthymic mood. There's no depression. It's just that person that doesn't have the drive to get up and do things, and it doesn't bother them. So what about depression after TBI? Why is it so important to talk about this? Well, first of all, it is the most commonly reported neuropsychiatric disturbance after traumatic brain injury, and unfortunately is associated with significantly decreased cognitive and functional recovery. It really impairs how well the patient will prognose in the future. What does depression after TBI really look like? So how is this different from what we would call idiopathic depression? Well, there's still the depressed mood. There's still the poor sleep and appetite, poor energy and concentration. There's a lot of feelings of worthlessness. Many times there's a demoralization aspect. It's, I can't go back to the functioning that I had before, so therefore I'm worthless now. I can't provide for my family because of this brain injury, so I really have no function. I'm a burden. There's a lot of negativism, difficulty seeing a positive outlook on things. And then there's suicidal ideation. These are also components of what we would see in idiopathic depression, but in TBI, patients with depression often have this anxious agitation. They're often very restless. They're often kind of on edge about many things. And this really impairs their ability to focus, in addition to having the depressed mood. And there's more of an irritable edge. So there's more sort of an agitated depression that we see in patients with TBI. And this has been very well studied by our colleagues in the early 2000s to have a very distinct phenomena from people that have depression but don't have TBI. Suicide after TBI, as we all know, is a very, very important topic to think about and to take extremely seriously for clinicians, for family members, and for the community at large. Patients with TBI are 4.9 to 8.7 times the risk of developing suicidal thoughts. The rates of suicidal thoughts is anywhere from 6.3 to 72.7%. Why is this prevalence range so wide? Well, a lot of the studies that look at patients that had suicidal thoughts after TBI are heterogeneous populations. So these are people that had depression before traumatic brain injury and may or may not have developed new onset depression afterwards. So it's a mixed bag of sample populations. The rates of suicide attempts, again, vary, but it's from 0.86 to 27.3%. Now, when you look at the top ways that patients attempt suicide and die by suicide, drug overdose and firearms are the highest. If you look at these graphs here, we're looking at different age groups, 18 to 29, 30 to 39, 40 to 49, 50 to 59, and greater than 60. And generally speaking, the highest rates come right in the middle, people from between the ages of 40 to 49. And the different colors reflect the severity of TBI, the light blue being mild, the middle blue being moderate, and the dark blue being severe. And what you will see is that mostly people with moderate to severe TBIs, the light blue is no TBI, the middle is mild, and the dark blue is moderate to severe TBI. So people with moderate and severe TBI have a tendency to have more suicide attempts, again, in this middle age range of 40 to 49. We see this pattern with drug overdose and similar patterns with the firearms data that we have looked at. When you look at suicide attempts after TBI and we look at male versus female, we find that males are more likely to have suicide attempts than females, generally speaking. And most important from this graph to take home is that the highest risk and the highest amount of incidence of attempts after TBI happen within those first 6 months. So really, this is what we call the acute TBI period, where patients are adjusting to the fact that they had this devastating event occur. And because of this event, they're really having all these psychiatric problems. And that's when suicidal ideation kind of takes a peak and kind of comes to a head. And as the years pass on, really the incidents start to drop. Similarly, when you compare patients who don't have any TBI to those who only have body fractures or body injuries and no TBI, to those who only have a TBI alone has a higher incidence rate of suicide attempts. And again, males more than females. So how do we manage these symptoms after TBI? What can we do to sort of not just capture these symptoms, but treat them and make sure that patients really not just get better, but stay better? So as a TBI neuropsychiatrist, I will say that I'm spending majority of my time coordinating and advocating for my patients with other specialists. So I'm working with physical medicine and rehab. These are the people that take care of physical rehabilitation, PT, OT, speech language, physiatry, all of these combined. Audiology, as I mentioned, that noise sensitivity and tinnitus can happen in patients with post-concussive symptoms. So I'm constantly coordinating appointments for them with that. Sleep medicine, because of the insomnia that ensues. Working with neuropsychology to address the cognitive deficits. Working with pain management, because again, we're working on lots of neuropathic physical pain symptoms. We're looking at nociceptive pain, lots of different types of injury-related pain that are affecting patients psychiatrically. And finally, neurology. Oftentimes, for the moderate and severe TBI patients, seizures is a big deal. And so post-traumatic seizures are something you really want to be working on and addressing. specifically because a lot of the medications that neurology prescribes overlap with psychiatric medications. So sometimes mood stabilizers can also serve as anti-epileptics. So we're really needing to have conversations with other doctors to make sure we're avoiding polypharmacy or too many medications. So we've done a lot of studies on what kind of interventions are the most effective to treat the symptoms and the syndromes of TBI. But the first thing that we want to ask is, what are we treating? So it's really important to look at whether it's depression, whether it's anxiety, what exactly is the target symptoms. There have not been that many randomized controlled trials in looking at antidepressant use in TBI, but of the trials that have been done, sertraline and citalopram, which are in the drug class of antidepressants, are the most well-studied and the most commonly used. So you may see these being prescribed. Oftentimes, for that aspect of lack of motivation or that anhedonia that we see in our patients, stimulants can be also prescribed. For those who have PTSD, they were in combat or they had some trauma related to they're experiencing the motor vehicle accident as a traumatic experience, we use sertraline, which has been very extensively studied and has a lot of evidence for use. Insomnia, we usually give hypnotics like trazodone or Ramelteon. For apathy, again, this is that person that doesn't care, but they don't care that they don't care. We give them stimulants, put a little bit of pep in their step to get them motivated to do things. And it's very effective. Particularly, a lot of studies in severe TBI have shown that people who had a lot of apathy symptoms really started getting motivated to do their things with a stimulant. For memory deficits and executive function, we often give cognitive enhancers. There are a lot of new drugs on the horizon now. For what's been approved so far, not been approved, but what's been the mainstay of use now are things like donepezil and amantadine. For inattention and other ADHD-like symptoms, we give stimulants, methylphenidate, lisdexamfetamine. And then for the post-concussive symptoms, patients often come to me with the neurological concerns being the primary, but then they realize that the psychiatric concerns are equally as important. But we really want to target the neurological complaints as well. So a lot of times for the headaches, for the migraine pain, for the trigeminal neuralgia that might happen, we can give things like gabapentin, which is a mood stabilizer, but it also helps with pain and anxiety. Or things like tricyclic antidepressants, nortriptyline or amitriptyline, which are antidepressants, but they're very effective for pain. But it's not always about medicine. And I always tell patients, a pill isn't going to fix it all. And we're always looking at multimodal, holistic approaches to getting you better. So the psychotherapeutic interventions that we focus on in our clinic, and specifically that our therapists look at, is working with patients to really enhance their functioning from various angles. The first is re-scripting the narrative. You had this devastating event happen to you. We may not be able to get you back to the way you were before your injury, but we can certainly get you better than you are now. Let's re-script your narrative and talk about how we can go forward to get you on the path of recovery. Supportive psychotherapy. Our therapists are trained in our clinic to really talk to patients about what they're going through, what it means to them, and giving them really mild and gentle guidance as to the next step. Cognitive rehabilitation. This is a highly evidence-based intervention used in traumatic brain injury. I call it the brain gym. We send our patients to neuropsychology to do specific exercises and tasks to really get that brain moving in terms of ways to remember things better, ways to keep yourself on task, to start a task, to finish it, to organize yourself. So I always say we're going to give you a referral to the brain gym so you can really use your brain as a muscle to get it rehabilitated. Behavioral therapies are extremely important. So working on mindfulness, because anger management and anger sensitivity is really a big deal that we deal with in TBI, we want to let our patients kind of think about, what are they hearing? What sounds are you hearing right now? Let's stop and take a deep breath. What do you see outside? Who's in the room with you? Being mindful of what's around them. And cognitive behavioral therapy. CBT is a very well-known intervention for depression and other psychiatric disorders. But in TBI, we have to be careful because there's cognitive pieces, there's homework, there's exercises that we have to tailor to our patients based on what they can tolerate. But it really is an effective strategy to say, okay, let's think about this thought that you're having. Is it rooted in a feeling? Is it rooted in a behavior? Or is it coming from some kind of a thinking that you're looking through a certain lens with? And finally, family therapy. I can't advocate enough how important it is for families to be involved in what's happening with the patient, and also having a chance for them to release some of their frustration and them to vent as the caregiver. What are some of the challenges that I'm experiencing providing for my spouse who now can't do the things that he used to do and provide for our family? Rehabilitation after TBI really is multimodal. In our program, we have an occupational therapist who works with our patients to work on task initiation. Can you go and make a grilled cheese sandwich? Can you go out there and let's start trying to figure out how you can plant a garden? Let's work on sensory integration. Let's work on, tactile sensations. Let's work on auditory processing things. Pharmacologic interventions, I've already mentioned some of the medications that we prescribe to help patients get through a lot of their therapies. If they can't focus on something, we can give them a stimulant to help with that. If they're having memory problems, we can give them a cognitive enhancer to help with that. Anger management, having groups of patients that you can have that are going through the same things you are, to work on ways to hold back that thought of anger before you say something, or how do you count to 5 before you react from a certain stimulus that just triggered you. Psychoeducation to caregivers is another really important piece to our treatment. We always want to tell parents and families and spouses of what they should expect. Maybe you have the expectation that your husband can walk like he used to, but that may not be the case. Let's start with where he is now, and let's go forward with what you can do to support. Mindfulness-based cognitive therapy, as I mentioned before, really hone in on what's in the here and now, in the present, and really allowing that kind of relaxation aspect to be integrated into their treatment. Vocational rehab is really important. It's not just about getting Mr. So-and-so to get his symptoms better. It's, can he eventually go back and do a job at a part-time level or do something that's a little less demanding, but really get him to do something that's productive for him so that he or she feels productive and feels a sense of accomplishment. And finally, the skills for social reintegration, having groups where people are actually given examples or role play where you can use particular phrases that might be appropriate and replace them with things that you may or may not have wanted to use before. So this type of holistic, integrated, multimodal approach of different groups is a program that we've created at Hopkins called the Head Injury Outpatient Psychiatric Enhanced Services, or HOPES program. It is a program that is 12 weeks in which patients come from all over the country to basically have groups that I just discussed 3 times a week, in addition to meeting with the psychiatrist once a week for medication adjustment and the therapist once a week. The idea is that we really want to minimize disability. We are all about ability, not disability. And we really want to be maximizing the function and productivity in adults who have sustained some kind of a brain injury. And there's the website for the brochure if anybody is interested in sending people. We've got these 3 A's that are the tenets of HOPES, which is that we want to advance wellness. What are you eating? What does your nutrition look like? How much are you exercising? What's your sleep hygiene look like? We want to help accept disability. It's that conversation of may not get you to where you were before, but we can certainly get you better than you are now. And attain the maximum potential. Okay, so you used to be a writer. You're having difficulty putting thoughts on paper. Maybe we can start by drawing something and getting your thoughts back down on paper so you can build up to writing again. The 3 R's, from looking at a healthcare system standpoint, people with TBI are constantly coming in and out of the ERs, in and out of the psychiatric units because of that irritability, agitation, disinhibition, without people really realizing this is a chronic thing that's not going to get fixed by a psychiatric admission. So HOPES really reduces hospitalizations, reduces the ER visits, and rapidly stabilizes symptoms in a very safe and well-monitored environment, 3 times a week, in groups, once a week with a psychiatrist and once a week with a therapist. So how can family members at large and the community, if you know people with TBI, how can you help? The first is educate yourself. You're starting by doing that today, by listening to what a TBI is, listening to what happens after TBI from a psychiatric perspective. Being involved in the rehabilitation process. If the physical therapist is giving exercises to be done at home, how can I be involved to help facilitate that process? If the OT is asking me to create certain sensory materials or create certain sensory environment in the home, what can I do to facilitate that? Establish a routine and schedule. Make calendars, a predictable schedule, knowing what someone's going to wake up to at the end of the day and start with the beginning of the day is going to be really helpful. support while encouraging independence. You will really want to be there to support your loved one, but you also don't want to do everything for that person, because the best way they're going to develop their confidence is really by having that independence to do these things. Develop to-do lists, post-it notes. This is what a lot of the cognitive rehab focuses on. So I can't tell you how many times my patients tell me, I have 500 post-it notes all over my dresser because I have to remember that I have PT Monday, Wednesday, Friday. I have my doctor's appointment on this day. I have to remember that my toothbrush goes in this area of the sink, whereas my toothpaste goes here. So these are really, really important to help with patients understanding and remembering of how to do these things. And finally, contacting the physician when new symptoms develop. So oftentimes patients, and we use a MyChart. Epic MyChart is a very user-friendly thing for us, and family members are often messaging me, I'm so sorry to bother you, but my daughter just started developing more confusion. Could this be something worsening? And then we'll have to figure out, was this a seizure, or should we refer her back to the neurologist? Should she go to the ER? So always contacting the physician when new symptoms develop. And so what is it about the path to recovery? What is it that's important to know? First of all, recovery is not a race. It's the long haul marathon. The old model used to be traditional model. Doctor has medical experience, uses an assessment to diagnose, treat the problem, promotes clinical recovery, and really the doctor has control. That's way back in the day. That's very antiquated. Now a recovery model is really looking at what is needed for well-being. What does this particular individual need to thrive? Not using a one-size-fits-all. Individually focused treatment is what's really important. While one person can get up 3 days a week and drive to PT, somebody else may not be able to do that. Can we do home PT? Do we do different types of PT? Can OT sessions be done virtually? Always looking at what the individual can do based on what their individual profile is. And promoting personal recovery. What are some of the goals that you have for yourself? Sure, your wife may want you to have this, your husband may want to expect this of you. What do you expect for yourself? And finally, you want to share that control. So I often tell patients, I'm the expert in brain injury, but you're the expert on you. You're the expert on your symptoms. Let's come together and meet together as a team to help you not just get better, but stay better. So where are we going in future directions with our research and with our program building? The first is really developing integrated care sites with collaborative clinics. I can't tell you how many times it's so taxing for our patients to come see me in psychiatry, then go to the downtown campus to see their neurologist, then go somewhere else to see PM&R, then somewhere else for neuropsychology. So really trying to build integrated care sites as a one-stop shop so everybody can come and get treatment in one spot. Intensive psychosocial rehab. So what we're doing with HOPES, we really hope to build across the nation that other places can start to adopt and integrate. Early screening through novel neuroimaging after acute injury. So as I mentioned, my project, my NARSAD project, is looking at patients with mild TBI right when they get into the ER and tracking their functional connectivity changes over the course of 6 months and associating those with depressive symptoms. Early interventions at the time of the presentation. From the data I presented to you today, now hopefully you are more aware that if someone comes to the ER with a concussion and they're male and they have a prior history of psychiatric illness, they are at high risk, or even females. Can we give them psychiatric follow-up or referrals upon their discharge from the ED? Lots of things on the forefront, on the horizon on neuromodulation. So repetitive transcranial magnetic stimulation or transcranial direct current stimulation, other types of neurostimulatory types of intervention for depressive symptoms after TBI are on the horizon. And finally, treatment trials, looking at glutamatergic agents, 4-deoxetine, levomilnacipran, and now ketamine. We're doing a lot of ketamine at Hopkins for depression, but now thinking about how would ketamine look in TBI for patients who are not responding to typical antidepressants. So in summary, TBI is a chronic condition. It's not a one and done. It's a sequence of events that can last a lifetime. Neuropsychiatric symptoms after TBI include most commonly mood symptoms and cognitive deficits. Treatment involves really multidisciplinary collaboration. For a psychiatrist, it's important for the psychiatrist to be looking at all other areas and all other disciplines of medicine and coordinating care with those providers. And for families to be involved, it's really important to balance that ability to be supportive while encouraging independence. So the next time you're hearing about a family member, a community member, a patient who struggles with a traumatic brain injury. It's really important to remember what they're going through, what emotional experiences they're having, the problems they're having with regulating those emotions, and to really understand that it's important to work integratedly to not just get them better, but to keep them better. With that, I thank you.
Well, thank you. What an extraordinary presentation. So much information presented in such a user-friendly way for really lay people to be able to understand, as well as professionals. I just wow. And so thank you for that. And I could definitely say that if, God forbid, I have a TBI, I'm coming to you for treatment, and your team. So wow. I don't know if nobody's put questions up in the chat, but I don't know if we can, if we can open it up and see if anybody wants to ask a question the old-fashioned way. Yeah, go take another sip of water. You've been going so strong, Dr. Roy. So, wow, that was amazing. Does anybody have any questions in the audience?
I have a question, and that is about your 12-week program. Can you tell us a little bit more about that in regards to if there's anyone listening today who thinks, I would like to do that?
Yes. So for those who are not in the Baltimore area, we are often taking referrals even from outside the state. People come and they kind of park themselves in Maryland for the 12 weeks. It's a 12-week program. What we have are skilled therapists that run those groups. So as I mentioned, it's 3 times a week where you have anger management, psychoeducation, the occupational therapy groups, mindfulness groups, all together, not all together, but they consecutively. So because people can only tolerate so many hours a day, the groups usually only last anywhere from 2 to 3 hours with lots of breaks in between. So in those 12 weeks, you go through a course, there's a curriculum, and you see the psychiatrist once a week for adjustments in medication, as well as if needed, and then as well as the therapist one-on-one individual once a week. The idea is that we want to see the progression. So we look at people who have mood symptoms, cognitive problems, behavioral problems at home, and we sort of have them go through the 12-week course. There's a graduation at the end, so people have a sense of accomplishment. And of course, we also, again, like to collect research. And so we like to see, did something like this help? So we keep track of mood scales, so the PHQ-9, the GAD-7, the post-concussive scale, the Rivermead post-concussive scale, the acquired brain injury behavior scale. So we look at objective data to also see if patients are getting better. So it's a 12-week program that happens through our clinic, and referrals can come anywhere.
Great, thank you.
Great. Yeah, wonderful, wonderful. Not sure if anybody has questions. You covered so much in your presentation. What did I think a question might have popped up. Okay, we do have a question. This person's cousin had a TBI many years ago and experiences hallucinations. Is that common? And he talks to the questioner about things that aren't real, that aren't really happening in real life. So very good question. Thank you for asking that.
Agreed. Very good question. So one of the reasons I didn't put psychosis up there is it's so rare. It's really like 1% to 2% after TBI, but it does happen. And so typically we see this often with people who have severe TBIs, and they may or may not have had a period of delirium after they became injured. So what we typically do is we treat the symptoms of psychosis. So if they're having auditory hallucinations, we have to be very careful because patients with TBI can really develop side effects very easily. So antipsychotic medications are not, we don't jump on them immediately, but if they're needed, as in this case, potentially would do very low potency medications for that.
Great, thank you, thank you. If somebody does have a traumatic brain injury, what do they do? What do you do? You're walking down the street, the terrible accident happens, or a moderate accident happens, go to the emergency room. They basically are going, let's say they say you're okay. So go home, what should you do above and beyond what I just described?
Great question. So the most important thing is to monitor the symptoms, because the symptoms are going to really ensue after you've already left the ER. So the next 3 to 5 days are going to be critical. That's when we start to hear people say, I had this really bad headache, I was vomiting, I'm having cloudy, thinking, my mood is a little off, I can't sleep. So monitoring symptoms, and then typically what ends up happening, and this is why I always say there's nothing mild about a mild TBI, because concussion is real, going to your primary care physician and asking for a referral to neurology, because it really needs to be addressed early. As you saw, there are examples when it progresses, it can become devastating. So watch for symptoms, go to the doctor immediately after you get discharged from the ER when they tell you that it's just a concussion.
Okay. And should people rest, rest in a not brightly lit room and avoid computers and that? Is that something that is real that people should do? You always hear about that. How real is that?
It's very real. Actually, my office, I keep it dim. And when people come in for the first time, I ask them, is it okay that it's dim? And most of them are saying, yes, please leave the lights off, because light sensitivity is very debilitating. Well, we try to tell people, because noise sensitivity and light sensitivity are the initially most significant notable things that a patient experiences. So we do try to tell family members to keep stimulus low in the house for those first couple of days. We're trying to develop a protocol for the ER doctors to tell the patients this as well. It's a work in progress, but we really like to have people have a very low stimulus environment. So yes, keeping lights dim, very little, a bit of noise. Also trying to encourage not too many people to talk at once to the patient, because that's a lot of distinguishing who's talking, and kind of a voice discrimination can be very sensory stimulating and overloading.
Great. Good. Well, I want to again say thank you for taking the time for this presentation, which was outstanding. And thank you for the work that you have done, continue to do, and will do, both clinically helping so many people, and just as importantly, the research that you are doing as well. So with that, I can't say how much I appreciate all that you're doing, and thank you so very much.
Thank you all, and I'm so honored to be here. Thank you for the invitation.